Parkinson's disease, as you know, is a very, very common condition. And, you know, it affects 3, 4, even 5% of everybody once you get to a certain age range. And we're all aware of the motor features, the movement features, tremor and slowness of movement and stiffness. And there are a range of non-movement symptoms as well, which may or may not occur. And it's important to be aware of these because they can, in fact, cause a lot of difficulty, excuse me, if they're not addressed appropriately. So in terms of the medication or the treatment, medication is an important part, and we'll focus on that today. But there are a whole host of other services and interventions and treatments that are very important for staying well with Parkinson's disease. And several of these treat things that, in fact, the medication doesn't particularly treat. So they're critically important. And as I'm sure many of you know, and certainly I know, access to some of these services can be limited depending on where you are or other factors. So there are certainly gaps in the non-medication treatment of Parkinson's, but just to highlight that it is a very important element of the treatment. In terms of the standard medications that we generally use and that most people will be on, the commonest, the oldest drug is Sinemet or Matapar. They are essentially a levodopa treatment, which is an attempt to directly replace the missing dopamine that occurs with Parkinson's disease. It's probably the most effective treatment we have. It's the most effective for tremor, certainly in terms of standard treatments. But the downside is that you must use it in a multi-time-a-day fashion, and there can be some specific issues in the long term with it. The dopamine agonists, which are a newer class of drugs, instead of replacing dopamine, they try to mimic or pretend to be dopamine in the system. And they generally come as a once-a-day preparation, as a tablet or a patch. And they're less effective in an overall sense in terms of the amount of movement improvement, but there are other benefits in terms of convenience. And they again have some specific side effects, which I'll mention briefly in a minute, which are different to levodopa. In terms of other drugs then, two other common medications, well, certainly one very common one are the classes of drug like Eldepril or Azilect, which a lot of people are on. And these in themselves aren't direct replacement treatments, but they work to allow any residual internal dopamine to work better, and certainly the levodopa to work better by preventing its breakdown. And in a similar fashion, Comtess, or if you're taking Stalevo, that's essentially Sinemet plus an extra ingredient. That again is to prevent the breakdown and prolong the effect of dopamine. And then in terms of other types of treatments which aren't dopaminergic as such, anticholinergic drugs are the ones that are more targeted for tremor. The problem being that they are poorly tolerated in general and can cause quite a lot of side effects, but there are on occasion situations where they can be very helpful if they're well tolerated. And then amantadine is a final drug which we don't use very much, except sometimes if there are specific reasons to do so. And the reason for that is, again, the side effect profile is not great. But the two, you'd be on either one of these two types of drugs at the top, levodopa, which directly replaces dopamine or attempts to, or a dopamine agonist, which mimics dopamine and tries to perform the same function. In terms of getting the most from medications, generally speaking, it's advised to take levodopa away from food. We say half an hour before or an hour afterwards, because there's competition for the absorption and protein in particular. So sometimes, because that can cause nausea, we do say it's okay to take a digestive biscuit or similar with it. It probably won't interfere too much if you're getting nausea just on the empty stomach. In terms of taking the medication at the same time every day, that's recommended for a couple of reasons. Often early on, it's not that important, and patients will say, you know, even if I move the doses around quite a lot, I don't particularly notice. But sometimes later on, it can be the case that the timing is more important to feeling well. And the second reason is that if we decide we need to make a change, then figuring out what change to make is dependent on us knowing what you're taking on a regular basis. And it's important to say that if you make a change to the times or the doses, we allow about 2 weeks before we see the full effect of that change, and you make a judgment, has that worked or not? So if you're changing every 2, 3, 4 days, you're really never settling the system, and it's impossible to know where the problem is if we're aware that something does need to change. And then just the Azilect or Eldepril drugs, we suggest taking them in the morning times generally. They can interfere with sleep. In terms of other types of treatments, the other general rules of thumb are that if we're making a change to treatment, we just try to make one change at a time. because if you make 2 or 3 changes and you don't feel well the next week, we don't really know which is the culprit. And the second thing, as I suggested a second ago, is that we allow time for when you make a change to decide what the effect of that has been. Has it worked well or medium, or has it not worked at all? And with most treatments, even outside of Parkinson's, when we start a new treatment, the side effects come in first, whether that's a bit of nausea, tummy upset, tiredness, and they always come in at the front end, and then the benefit often isn't seen till a bit later. So with side effects, the advice is really that if there are mild side effects that are expected, you see if they peter out over a few days and go away. Clearly, if they don't go away, we're probably not going to be happy continuing. And the second thing I would say is that if there are severe side effects, then you're always at liberty to just stop the treatment and let us know so we can think again. But I guess in terms of milder side effects, it's often worth seeing if they go away over a few days or a week. And then at a later time, the next week or two, seeing what the benefit is or not. And then alternative therapies were often asked about, and there are a huge variety of different modalities. In general, none of them particularly interfere with any of the medication side of things. The advice would simply be to go to someone who's a reputable source of treatment or has a good recommendation or reputation, and just to keep track of the costs, that you don't end up spending an awful lot on things, especially if we're, depending on what benefit you're getting, it's not clear how much it's adding. But aside from that, there's no particular reason if a particular treatment works for a patient to not do it from a medication perspective generally. In terms of symptoms to watch for, there are a huge number of symptoms that come with Parkinson's disease anyway, and they fluctuate. By its nature, Parkinson's disease changes day to day, week to week, and then very, very slowly over time. Often there is a shift in the overall pattern of symptoms. If you have a new problem on a given week, it could be part of that Parkinson's disease and its fluctuation. It could be something that occurs normally with Parkinson's disease, such as sleep disturbance, being made worse by one of the medications. And we need to figure that out. It could be a direct medication side effect. An example would be ankle swelling with dopamine agonists is a specific side effect that's not something related to the Parkinson's in particular. And then, of course, it could be something that's not related to Parkinson's. So very often patients will say, or a GP will say, there's been some weight loss, and we would never assume that weight loss is due to Parkinson's until we've checked for other causes. And you're like everyone, patients are entitled to have more than one thing wrong with them. So you always have to make sure that whatever you're looking at is not a totally different process that needs a different assessment. Oh, sorry. And then the diary. So there are multiple ways of taking a diary. It's quite laborious, and so patients and carers often find it difficult to keep a diary for a long time. We often would suggest a couple of days in a row just before your next visit. And all we're looking for is for each hour in the day, do you feel your movement is good? Do you feel your movement is off, so you're stiff or slow? Or do you feel you're overactive with the movement? Is there dyskinetic activity or any other problem? And it's just one of those three options in each hour. And that helps us very much to see where the problems might be. And it helps patients as well to think over how their day is and really very clearly identify where the problems are, so we can be really targeted in the clinic and we can really try and make the best effect with any changes. Specific examples, sorry about the typo there at the top. So dopamine agonists, some particular things, if you look in the packet for any of these drugs, there'll be 100 side effects, like most things. Aspirin, paracetamol, the same. But dopamine agonists, two things we always particularly counsel about are effects on sleep, and particularly sudden onset sleep during the day. Excessive daytime sleepiness is common anyway, but this could be exacerbated by dopamine agonists. And the obvious reason to think about it is driving. That if you're having this, we want to get rid of that problem so you're not feeling worried about driving. And then impulsive and compulsive disorders, they can occur with Cinemet as well, but they're more likely to occur with agonists like Requip, Nupro, Neuropexin, those types of drugs. And essentially what that is a subtle or more marked change in behavior. So somebody might become a little bit more impulsive or compulsive, so shopping a bit more online, gambling a bit more if they're already doing these things. It's generally an increase in an existing habit or hobby, and it becomes more intrusive. And that again can be an effect of the drug, and just to be aware of that. Levodopa tends to be better tolerated generally, apart from the multi-time a day dosing. And then the longer term, we'll talk about in a second, some of the things we need to watch out for in terms of specific side effects that can occur, like dyskinesia. Exelon is a medication as a patch or a tablet that we sometimes use to boost memory function in patients. And the particular side effect there to watch for is postural lightheadedness. Standing up from a chair, from the bed, you feel lightheaded, nearly fainting, or actually fainting. And that's the thing that can be made worse specifically by that drug. And then, as I mentioned already, the anticholinergics, that class of drugs that we don't use very much, and it's particularly good for tremor, it's quite common for that to cause a degree of confusion, and often we're limited in using it in a lot of patients. And constipation, which is a problem anyway with Parkinson's, can be worse with anticholinergics. In terms of motor complications and some of the more infusion-based therapies, I'll just very quickly go through the reasons to do those treatments. So aside from the tablets we talked about already, there are other types of treatments, things like duodopa, apomorphine, we'll talk about them in a second. But generally speaking, the reason to use those newer therapies or different therapies is if you're having a change in how you're responding to the tablets. So generally at the start of Parkinson's, you take a dose, you get up into a nice effective range here. So this green area is when the blood level, which is this here, gets up to the point where you're feeling good. The movement is fluid, reliable, stable, and then you come back down again, you need your next tablet. What can happen later on in the condition is that you take the tablet and it can overshoot, number one, giving you dyskinetic movements. And the time you're in this green zone is less. So you're getting less time from a particular dose of Cinemet. And some people in the audience may be well aware of this, that we need to move the doses closer together or take other approaches to counter the wearing off. And then it can become the case that even with making changes, you're not able to get the day nice and even with the tablets, no matter what way you arrange them. And that's where you would use some of the newer treatments, which are these types of treatments here. So the three we talk about are apomorphine, which is a pump that it delivers apomorphine into the subcutaneous space, so a little needle into the skin surface, exactly like an insulin pump, for example. And that drug, apomorphine, is analogous to Nupro or Requip. It's a dopamine agonist. Duodopa is a treatment which is a little bit more involved, and it's where you put a little tube into the stomach, push it down further into the small bowel, and you essentially deliver a gel, which is Cinemet, but in gel form, and you get a nice even response during the day. And then the last one is deep brain stimulation, where you directly stimulate one of a number of sites at brain level. And the main reason to do any of these treatments is if you cannot get the day movement nice and even by readjusting and moving around the times of the other tablets. So they will be second line treatments. In fact, none of the drugs technically chemically are new drugs, but there are newer ways of giving them. Okay. And then the other question we're often asked about is current research. And there's a huge active community of researchers in the Parkinson's area. There's overlap between Parkinson's disease and several other neurological conditions. And the likelihood is that a treatment that's useful in one may have applications in another. And the domains where research happens are in not just in the therapies in terms of treatments, but also assessment tools, diagnostics, scanning approaches, rating scales, and then symptomatic treatments, which are to help symptoms. And of course, what we're all really interested in is disease-modifying therapy, which adjusts how the condition changes over time intrinsically. So in terms of drug development, and people may be slightly more aware of these types of phrases now because of the vaccine trials, which everyone's reading about all the time. So from a drug going from a preclinical discovery in a lab where you find a chemical and you think this could be potentially useful in X or Y condition because you've done some cell-based work, you have to go from that through three phases of clinical trials. The first phase is simply to do with safety. The second dose is safety in a bigger group, and is there any signal for efficacy or that it works? And if that's the case, the company will fund a phase 3 trial. And it's only after these trials that drugs can potentially be licensed. Although, again, as you may be aware of, the FDA can accelerate that process. Phase 4 is when a drug has been licensed, it's in use, and there's post-marketing safety monitoring. So in terms of the current trials happening in Parkinson's disease, you probably cannot see the detail on this, but it's just to give you an idea of the number of different therapeutic agents that are currently being trialed in phase 1, phase 2, and phase 3. And they're everything from symptomatic dopaminergic therapies, to antioxidants, to immunotherapies, to other types of treatments. And the ones we're particularly interested in, of course, are phase 3, because they're the next ones to potentially come on stream for prescribing purposes if they're successful. Where are trials happening in the world? I mean, trials are heavily centered in the US and Europe. The issue with doing clinical trials generally is that a company wants to open a trial center where they can get enough patients through to demonstrate what they're trying to demonstrate. And that's a challenge for doing trials in this country, which is a smaller country than, say, the UK or France or Germany, where most companies will always set up a center. And there is work which is very slow to progress, and it's been delayed a year now with COVID, to try and come up with a mechanism whereby the country as a whole can be seen as a center to be much more attractive for a company to open a trial center on site. Because as you probably will know, trials in other countries, you can't necessarily engage with those unless you're a resident of that country, even if you're prepared to travel. And then I suppose this is just, again, showing those phase 3 agents, the kinds of treatments that are currently being looked at in terms of potential usefulness in Parkinson's disease. And I suppose the expectation every year at the MDS, which is the big US EU conference, is that one or more of these will have some phase 3 evidence or results which we can debate the usefulness of. In terms of recent drugs that have been approved, so just to show there are drugs coming through that have been approved in various jurisdictions for different uses. So some of them are variations on existing treatments. So an inhaled levodopa agent, for example, or a sublingual apomorphine agent instead of using a penject. And other drugs then are potentially more interesting because they're different mechanistically to the drugs we're currently using. In terms of where these drugs are, or when these drugs are available in a particular country, it depends on other things like licensing and then eventually funding. So even at the point where a drug is licensed by the FDA, it can be a while before it's licensed in the EU or vice versa. But the point being, there's a hugely active and progressive range of treatments coming through. And I suppose the other one, sometimes people ask about the Leuconil drug, as it's called. So that's a medication which basically is looking at the fallout from an inflammatory response that occurs in lots of conditions, not just Parkinson's, but potentially Alzheimer's. That is a drug which is really at the point of Roche, which both the drug, entering phase 1 to 3 trials in Parkinson's disease and related conditions. There is a trial published in a totally different condition, an autoimmune condition, showing that it's safe and there may be some signal of effectiveness. But in terms of that pathway through phase 1, 2, 3, that's not imminent, but it's certainly one of many agents, as you've seen, that will be coming through on a year-by-year basis. So really the summary is, and I've gone on slightly longer than I had planned, I'm sorry about. So Parkinson's disease is very common, very treatable, lots of current treatment options, and there are multiple ways to get the most out of those. Plenty of upcoming treatment options, and a very exciting area where hopefully we'll be able to make more and more of a difference as newer options become available to us. So that's it from my perspective, and I'll stop.